this is a topic probably, neglected by women, by the patients, and by the imaging specialities as well. So I think that's why this is, really important to discuss about this. This is what I always feel. And it is very simple. It is very easy to learn about this in a day-to-day practice. The clinical indications for the pelvic floor ultrasonography are mainly urinary incontinence, symptoms of voiding dysfunction, recurrent urinary tract infections, fecal incontinence, and then of course pelvic organ prolapse, which is the main indication. And maybe this is a forum of a gynecologist, and you might say that you don't really need an imaging to diagnose these things. But because of the anterior compartment, posterior compartment, and these subspecialties, it is really important. In fact, if you get, if you refer these patients before surgery for imaging, you get a lot of insights. The other kind of little less common indications will be symptoms of obstructed defecation, suspected pelvic floor dyssynergy. The very important indication will be follow-up after pelvic floor surgery. We will see one or two cases in the end. So the surgical management depends on understanding of the structural integrity and the function of pelvic floor. So it is both anatomical and functional. And that's why, in fact, there is a lot of resistance to learn about this, because a lot of disorders are functional disorders rather than just anatomical ones. The imaging is by 2D, 3D, transperineal ultrasound, a TVS, and the endoanal imaging. Of course, we know the advantages of the ultrasound: no radiation, relative ease of use, minimal discomfort, etc., etc. But the complexity of the pelvic floor anatomy, the conceptual difficulty in basics of some of these pelvic floor disorders, and the uneven standardization of the ultrasound technique, its reporting parameters, that is what makes it little, less practiced modality. How do we do it? Patient is, in that routine TVS kind of a position. It is a dorsal lithotomy position. Hips are flexed and abducted. Of course, they are, resting on the bed and just flexed at the hips and the knees. We do it with a simple convex transducer, which is positioned between the mons pubis and the anal margin. And we scan the patient at rest on
Dr. Alpana, your slides are not moving.
Is it moving?
It's going out of the margin, I think. I don't know why. Only 1/4. It's too much zoom, it seems.
1 second. I think I will change it to...
No, we can see half of your screen only, which is zoomed out.
No, I'll make it little this... 1 second.
I think, Bela, it's quite correct.
Okay, fine, fine. Then maybe my some. Okay, Dr. Alpana, carry on, please.
I will just.
No, carry on. It's okay.
Yeah,
it's okay.
Once you see it, I mean, I'm just now again starting it as a this.
Yes, yes, yes.
What we see on 2D image is the bladder, urethra, the vaginal wall, anal canal, and the rectum. So, see, this is how the probe is placed. First, I'm going to talk about 2D imaging and then the 3D. 2D itself gives you a lot of information. So this is the anatomical picture, what you are seeing here. And this is the symphysis pubis. This is the urethra, the anechoic structure. This is the bladder. This is the collapsed vagina. Sometimes you see small air echoes inside. And this is the anal canal, which is devoid of any stools. So it is always collapsed. And this is the typical bowel signature. And this is the rectum, which is, there are feces and stools inside, air, and it gives a lot of reverberation. So you don't see it really well. So this is where the probe is placed. And this is the typical picture, what you get. So this is a image. This is the bladder. This is the symphysis pubis, the anechoic structure. What you see is the urethra here. Then there is a vagina, and this is the anal canal, and this is the rectum here. So this is a normal kind of examination. What we do, what we check is the detrusor thickness, the bladder neck mobility, and we look at, if there is any urine leakage. We look at the urethral integrity and we look at any cyst, masses or diverticuli there. Then some of the measurements, what we take is bladder symphysis distance, any bladder neck descent. But mind you, it is a lot of eyebolic kind of diagnosis. You don't really need to take a lot of measurements to diagnose these things. So the bladder neck descent, BND, of more than 25 millimeters, or some studies say 20 millimeters, will tell you that there is a hypermobility of the bladder neck. And then there are some angles like retrovesical angle and anorectal angle. We will see as and when we are seeing these cases that you don't really need a lot of calculations. So this is just the the distance what we take, symphysis pubis, and this is the urethra here, starting of urethra. So this is the bladder neck. So this is how the distance is measured, and this is the posterior wall of the bladder, and this is the urethra. So this is the retrovesical angle. Again, as we will see while doing the dynamic scanning, this is when the patient is performing Valsalvas. What you have to look at is, this is the bladder base. You have to see that it doesn't really go beyond the symphysis pubis. You have to also keep a watch on the bladder neck, the urethra, where it starts. So this, the bladder neck, it should not be really going down, and you should look at the mobility of the urethra, how it is moving and how it is opening up. Now see here, whenever any patient performs Valsalvas, the organs are going to descend down, but they are not going to go beyond the symphysis pubis. So if you compare it with this, now this patient is performing Valsalvas, and look at that bladder base. It has gone much beyond the symphysis pubis. Where is the urethral opening? This is the urethral opening. That is also going down below the symphysis pubis. So there is cystourethrocoele and there is only cystocele. So that is how we differentiate it from here. Now look at this bladder neck. It is remaining here at the level of pubic symphysis. It is not going beyond the symphysis pubis, but the bladder neck has gone beyond the symphysis pubis. So then this is how we, take the distances. But again, as I said, a lot of things are on the eyebollically what we are seeing rather than taking the distance. So as I said, we draw a line at symphysis pubis and we take a distance of bladder neck, and then we see how much it has descended down after performing Valsalvas. So this is how you will calculate that. So isolated cystocele, where the retrovesical angle remains intact and bladder neck stays at rest position at the level of pelvic bone, but the lowermost point of the bladder base is below the bladder neck. And it is more likely to be associated with levator trauma. Women with this type of cystocele tend to suffer more from voiding dysfunction than from the stress incontinence. So this is how you will see, look at the bladder neck and look at the bladder base. This is the symphysis pubis. So it remains, the bladder neck remains at that level, and the base is going much beyond the symphysis pubis. So this is going to be just a cystocele. Whereas what is a cystourethrocoele? Where both the bladder base and urethra will form one smooth surface and everything will descend down. As you can see, even at rest, everything is, down. This is the bladder base. This is the bladder neck here. Look at that. This is the bladder neck, and everything is gone beyond the symphysis pubis. This was even at rest. So this is like a cystourethrocoele. The other indication is for the urinary incontinence. Stress urinary incontinence and urge urinary incontinence. So stress incontinence is because of the poorly functioning urethral sphincter or hypermobility of the bladder neck, whereas urge urinary incontinence is due to the detrusor overactivity. So whenever you see it on ultrasound, you see there is a funneling of the urethra. There will be a leakage of urine seen in the urethra. When the woman performs Valsalvas, you will see the funneling of the urethra. So this is how you will see, this is, the patient was not able to do a very good Valsalvas. So you tell her to, kind of do coughing. So as you can see here, this, this place where the urethra is opening up, there is a leakage of urine there. This is when the patient is performing Valsalvas, and you can see normally you don't see, this is while doing Valsalvas, and there is a leakage which is seen like this. So this is a stress urinary incontinence. And the urge incontinence is mainly because of the detrusor overactivity. So how can you, measure that? So bladder wall thickness is the indirect measurement of detrusor thickness. So what we do is either on transvaginal or transperineal scanning, we do the bladder wall thickness measurement, simple thing. Now, mind you, here the bladder does not have to be very much distended. If the bladder is over distended, the walls of the bladder will become thinned out, and then you don't get the correct measurement. So the bladder has to be empty, little bit full, but less than 50 ml of urine. So that has to be remembered. And then we take the thickness at 3 places, at the thickest parts of the trigone, the dome, and the anterior wall. And the mean is calculated. 5 millimeter or above is associated with detrusor overactivity. So this is how we take at 3 measurements, and then we take a mean of that, and the bladder is almost empty. So that is what remains to be seen. The another important aspect of the pelvic floor imaging is, levator activity. Pelvic floor exercises is the first line of treatment in urinary incontinence, and it all depends on levator muscle function. So levator contraction, it causes reduction of the size of the levator hiatus or that pelvic hiatus. So uterus, bladder, and urethra, in fact, will be displaced cranially. When the patient performs Valsalvas, all the pelvic organs will descend down. But when the woman, contracts her pelvic floors, what happens is the hiatus will become small and all the organs will be pushed cranially. So that can be, seen very well on the ultrasound when we are doing it actively. So this is the symphysis pubis, and this is the anorectal junction. So if you take this distance at rest, if you take this distance at Valsalvas, and if you take this distance at contraction, they are going to be different. At contraction, this distance is going to be less. At Valsalvas, this distance is going to be more. So when we tell the patients to perform, see, look at this. This is at rest, almost 5 centimeters. And when the patient performs contraction, pelvic muscle contraction, it is at 3.8 centimeters. So look at this clip. I'm telling her to contract. Now, see, this is relaxing. Now she is able to contract, and this is going to, become small in size. So if the patient is able to perform that, look at that. And all the structures have moved, in fact, cranially. So she is able to do that well. In fact, in the Western literature, you will see references. The physiotherapists are using this as a tool to make the woman understand while teaching them the Kegels exercises. See, look at that. You are doing well. You are contracting your muscles, and look at the way the structures are moving. Of course, in India, when we are fighting over who can touch the ultrasound machine, this is a dream to do it. So we really won't achieve that state of training. So the practical tips are whether the bladder should be very well distended, empty, what do we do? So a partially distended bladder is better. When you are taking bladder muscle wall thickness, empty bladder is good. You should avoid undue transducer pressure on the perineum, so that you allow complete descent of the organs. Bladder neck descent, urethral rotation have the strongest association with the urodynamic stress incontinence, and the bladder neck descent cutoff is about 25 millimeter. Now with this, we come to posterior compartment. Rectum, anal canal, external and internal anal sphincter trauma, fistulas, all these things. Rectoceles and enteroceles. So you place the probe transversely over the perineum. Look at this. So this is how the image what you get of the anal sphincter. This is how typically you see the anal sphincter on ultrasound. So this echogenic round kind of a thing is the external anal sphincter, and the internal hypoechoic structure is the internal anal sphincter. This is the collapsed mucosa of the anus. This is typical bowel signature, what we call. So then whenever you have any abscesses, look at that. This abscess, if it is communicating with the anal canal, or if it is, kind of invading these sphincters, all these things can be made out very well on this transperineal scanning. Now look at this. This is the kind of the abscess which is there, which is, coming till the external anal sphincter, but not the internal anal sphincter. There is no communication with the anal canal or the bowel. So these things can be seen very well on the ultrasound. Now, if you notice here, the patient is performing Valsalvas, the bladder neck and the bladder base are not descending down below the symphysis pubis. But do you notice something here? In the posterior compartment, look at that. There are some kind of bowel structures, the air, something which is, coming down like this. So this is about the posterior compartment. This is looking at the posterior compartment, and this is typically an enterocele. Look at these, different moving mobile bowel structures, and probably omental fat, all these things are coming down. So that is the herniation of fluid containing peritoneum, small bowel, sigmoid or omentum into the vagina, separating the vagina from the rectal ampulla. So that causes downward movement of isoechoic or hyperechoic abdominal contents anterior to the anorectal junction. So that is typically the enterocele. Whereas rectocele is the rectal mucosa, which is, kind of protruding down through the rectal wall. So, this is the anorectal junction, and you will see something which is, going out like this, the rectal content, which is coming down from here. So that is the rectocele. And this is how, again, we take the measurement. And as I said, it is a lot of things are eyebolic, but the measurement of 10 millimeter descent from that anorectal junction is what we call as the rectocele. With this, we will take a quick look at the 3D scanning, how it is helpful. So this is typically the pelvic hiatus, when as if the woman is, lying in the lithotomy position in front of you. And this is a 3D image. Now look at that. It really resembles it so much. This is the complete hiatus. This is the urethra. This is the symphysis pubis. This is that, levator ani muscle, which is there at that, around that. And this is the anal canal. So that typically, gives you this kind of a picture, and a volume probe is kept, convex probe is kept over the perineum. And this is how you get a typical picture like this. There are again, a lot of measurements described in this. Maybe as a radiologist, it is more important. But what I want you to understand is, usually the measurements are taken at rest. And if you see, with pelvic muscle contraction and with Valsalvas. So the measurements are always given as, three kind of different measurements: at rest, with muscle contraction, with Valsalvas. So this is less than at rest, and at Valsalvas, it is always more than what we see here. So this is generally the levator hiatus. This is the pelvic hiatus, which is that dimension. This is the transverse lateral to lateral hiatus. This is a gap between the levator and the urethra. This is entire hiatus area. This will be the pubovisceral muscle thickness. And if you see, this is a nulliparous woman, and this is a woman with the prolapse. So you can see that the hiatus itself is so much roomy and, so much kind of wide like this. So these are generally the measurements. Nowadays, with a lot of artificial intelligence, some machines, just give you the automatic calculations. So, if you see here, if you just take these two measurements, it just gives you all the measurements which are coming there. You can adjust it a little bit here and there depending on the imaging. But again, these are not really all that important. Apart from in the cases of prolapse, something like this. This is normal, and look at that. This woman with the prolapse. Look at that circumference. The hiatus is, 25, and here the normal is around 11 and 12. So this is how you get the abnormal parameters in a patient with the prolapse. And this is how you will see, this is a child, this is a woman with, first or second para, and then the pelvic floor prolapse, and the hiatus is becoming wider and wider. If you notice, this is the pelvic floor 3D, and if you notice something which is going, outside like this. So what is this? This is a levator muscle tear. And again, that is something, which is a part and parcel of the birth trauma injuries. after the normal delivery. So these are the tears of the levator tears, and look at this. This is a normal urethra to levator distance, and if you take this is increased and there is a bilateral tear. Now these are the women who will not be able to perform that Kegel's exercises how much ever you try, because they have that their pelvic muscles are not really intact. This was a patient who had some swelling, and she used to say typically after some days it some fluid comes out and then the swelling goes away, and this was typically periurethral. The doctor wanted to know whether it is communicating with the urethra or not, whether it is separate from that, where is it exactly. So all these things will be seen especially well on a 3D reconstruction. This is the urethra, and you will see it is all going along that, but it is not communicating with the urethra. This was typically the urethral glands in that perinative, which causes the problem, and this was easily evacuated during the surgery. This is the posterior compartment, and that is the 3D picture. Again, any tears of these sphincters will be seen really very well on that 3D. It is a multi-slice kind of a CT kind of a MRI kind of a picture, where you will see that there is an internal sphincter and external sphincter which has got damaged, probably because of the old birth injury. The abscesses, will be seen. This was a patient post normal delivery. The wound was not healing, and the gynac was worried what is happening. Now look at this. This is the external sphincter which is involved, and the wound is coming right till that episiotomy cut which was there 2 months post delivery. Also it had not really improved. And if you see here in 3D, you had used to this image now, and we know that this is the levator NI here. So if this is caused some tear there, hematoma, in fact this needs to be followed up 6 months post delivery to see if there has been any trauma. You will see a lot of literature in the Western literature that as a protocol, they do this pelvic floor assessment at the end of 3 months and at the end of 6 months in all those who delivered normally, so that we know what is happening to these pelvic floor muscles. So in the end, do we need imaging for pelvic floor dysfunction? Yes, a proper diagnosis is a precondition for the appropriate management of any clinical condition. The best surgical treatment, even in the hands of the best surgeon, is likely to fail if it is performed for the wrong indication or on a wrong patient. So it is becoming increasingly clear that assessment of the levator NI morphology, the functional anatomy of the entire, means the anterior compartment, mid compartment, and the posterior compartment, should be an integral part of pelvic floor labs assessment, preferably by imaging. Improvements in the diagnostic protocols will have positive effects on the surgical research and clinical management. However, due to limited opportunity for teaching in this field, it will probably take more time before this potential is fully realized. So a last 2-3 slides about post-operative assessment. What is usually done is that mid-urethral position of the sling, and that needs to be checked. Now this will be seen best on a 3D ultrasound, because on 2D ultrasound you won't be really able to make out that. So what we do post sling placement is again the predictor of success after suburethral sling is by the bladder neck descent. And what we do is the sling pubis gap, that is the measurement. If we tell the patient to perform Valsalvas, what is the sling doing? It is just trying to, kind of compress that urethra and not letting the descent or the incontinence to happen. So we just measure that distance, that how effectively it is, tightening it. And that gap over 15 millimeters suggests insufficiently compressive gap, tape. So we will, see that. Now, this was a patient who had lost all her previous records, and the surgeon, the gynecologist did not know what kind of a tape which was inserted. So this on 2D, you will not be able to see anything. This is a tape because this is a very echogenic structure. This is the urethra here. But when you do a 3D reconstruction, you know that this is a transobturator tape. So, and it is placed well. This is the urethra. So obviously this is going to, kind of hold that urethra in place and not allow the incontinence and the prolapse to happen. So look at this. This is the transobturator plate, and this is the sling. Look at that. Now, if the patient is performing Valsalvas, this is the pubic symphysis and this is the tape. So this distance needs to be measured. See, look at that urethra. It is, keeping it there and not letting it cause any problems in this woman. So this distance, if it is more than 15 millimeters, this tape is not compressing enough. So that is how we look at it. Now, if you have learned something, learn to observe, do you notice something here in the posterior compartment? Look at that. So this patient is complaining of, something coming out per vagina, and, the tape was properly placed, but this is because of that enterocele which is there in the posterior compartment. So that needs to be seen. This is a transobturator tape. This is a transurethral tape. So all that is seen better on the assessment by 3D. Well, scenario in India is all about lack of awareness, resistance from clinicians, limited surgical treatment, and the limited teaching facilities. So that needs to be, kind of changed in Indian scenario. Thank you very much for inviting me for this odd topic, which is actually, very dear to my heart, probably. Thank you, Dr. Bela. Thank you, the Gynec Forum, for giving me this opportunity. I will stop sharing my screen.
Thank you, Alpana. It was a very interesting talk.
Thank you, sir.
You created an awareness amongst all the gynecologists to send the patient for sonography at least whenever we have a case of prolapse.
Yeah, thank you, sir. I have been doing it as out of my interest on, any patient who comes with prolapse. In area where I practice, few clinicians who know about it have been sending patients, and that is how I've collected my data. But it is an interesting field, easy to understand, and very helpful to the patients.
Now, I have few questions for you, Alpana.
Yes.
You talked about levator and neck. Can you identify piriformis and coccygeus muscle on?
Not separately, sir. It is all that together. Yes.
Okay. And always you do in Valsalvas and the Kegel's exercise mode, or you do only in Valsalvas?
No, we always tell the patients to contract once, so that we know whether that levator, muscles are functioning properly or not. We prefer to do that always.
Now, your pictures were so crystal clear. I wanted to know from you, because the treatment differs. In a case of SUI, we all know that it can be due to intrinsic sphincter deficiency, and second possibility is hypermobility. Now, hypermobility is the commonest thing.
Okay.
Can you identify on sonography that this SUI is due to intrinsic sphincter deficiency?
The urethral sphincter we can identify, but then we can't really identify the defects or something like that. But the hypermobility will be always seen on ultrasound, because the urethra kinking and urethra moving down and the angle changing, that will be seen very well. But specifically what you are asking, I understood that. I'm not really read the references about it, but I will then try and find if there is any literature on this. I'm not sure about
now,
this.
do you do sonography in these pelvic floor deficiencies in left lateral position?
No.
Or it's always dorsal?
Always in the lithotomy position. Always in the lithotomy position.
When to do TVS, translabial, transperineal, and transrectal sonography?
Transperineal with the convex probe is the best.
Okay.
Because the TVS probe, you can't really hold it over the perineum because of that small footprint. So that becomes a problem. So transperineal, if you're doing with the convex probe, is the best. The transrectal we don't need unless you have the different probe which has, side firing and the end firing, both crystals. So that is a totally different. Endoanal ultrasound is a different technology. So if you try and read the literature on pelvic floor imaging or the anal sphincters, you get a lot of images which use that double firing probe, which is a special probe. Like normally what we have, the transvaginal probe has only at the, curvature, the firing crystals are at the top. This probe has a firing crystal at the side and also at the top. So then if you introduce it in the rectum, you will see the rectal sphincter, anal sphincter very well. So but unless you really have that particular instrument, you can't use that. So transrectal is out of question.
Okay.
So it is mainly only the translabial scan which will be helpful.
And that is, we can use the volume probe that we use for trans.
Yes. And 2D itself gives you so much information that your routine convex probe, even if you don't have a 3D probe, can be just kept over the even the anal sphincter will be seen very well. So when I am training the radiologist, what I tell them is that in all your follicle patients, try doing this. Try identifying these structures by just keeping a probe. I mean, a TVS probe can be kept over the mons pubis and somewhere there, and anal sphincter can be seen very well. And it can just longitudinally held before you put it inside. You will see the pelvic floor very well. So that is how I usually tell the radiologist to learn that.
Thanks, Alpana.
Thank you.
Over to you, Bela, if anybody else has any question in chat box.
Thank you so much, first of all, Dr. Alpana, for a wonderful, wonderful presentation and insight into a new area for us, obstetrician, because we do not do generally perineal sonography. So this, I am sure, must have stimulated so many of the obstetrician and gynecologists to learn this technique and expertise this. So thank you so much, Dr. Alpana, and it was a very, very wonderful presentation.